sharing my slides. This is about to acknowledge, to inform you about the WFNS recommendations on back pain. Actually, as you know, we classify back pain in acute and chronic back pain. And chronic pain syndromes are quite different than acute pain syndrome. And if it is after 3 months of persistent pain, of acute pain, then we need a multidisciplinary approach, psychotherapy, occupational therapy, and exercise therapy. And these recommendations do not deal with chronic back pain. Acute back pain is mostly after intense exercise or a heavy lifting. Sitting and standing are painful, and flexion is painful, and you can find trigger points. As I mentioned, chronic back pain is quite different, and then we need different painkillers, additional neuropathic component, and mobilization exercise will benefit the patients. These are some sentences about the epidemiology, etiology, and prevention. The prevalence is quite high. And we also describe the most common acute back pain reasons as ischogenic back pain, facet joint pain, sacroiliac joint pain, and myofascial pain. And as you know, there are even some other, some of them are bizarre descriptions, but many different. The fact is, the diagnostic errors of acute back pain are common, and no relation with pain source and radiology. I commonly give this example. This is a L5S1 ischemic disease lady at 62 years old. She described for 6 months right leg pain, but on the many people would think that fixing it at L5S1 level with interbody fusion probably would be very helpful. But the examination was showing that it is a sacroiliac joint pain, and we did a test injection. It responded, and her pain completely relieved by RF lesion of right sacroiliac joint. So this is not true that we cannot rely on radiology. And if there are red flags, we must order radiology, especially MRI. And there is strong evidence that routine imaging for acute low back pain does not provide clinical benefit. What are the red flags? Red flags we all know, and we even teach them to the medical students. In these instances, we must ask for further tests, mainly MR images. The question is, do you order MR in all low back pain patients? If there are red flags, yes. The answer must be this only. The sources of axial pain are unpredictable and no tests are necessary. Most of the patients with axial pain do not need any therapy. They heal spontaneously. And this is very important to repeat in our minds, that there is almost no correlation with radiology and degenerative spine symptoms, and radiologists report lumbar disc herniation in 25% of normal population. However, if we order a radiology in all low back pain patients and we see disc herniation, and we make some surgeries for those disc herniations, and we can have no pain relief, and then we will be accused by the patients that we are doing unsuccessful surgeries. So we repeat again the operate the patient, not the films. It is estimated in the United States if they order MR images in a year, they must order 3,800,000 MR images. This study by Chu et al. Has compared two groups of patients. One group at the startup, they ordered MR images. The other group, they didn't order anything. They just managed conservatively and wait for 4 to 6 weeks. And in comparison, pain and function did not improve with early lumbar imaging. So this paper is from 2012, application of less is more to low back pain. And not imaging patients will reduce harms and costs without affecting clinical outcomes. These are role of drugs for our recommendations, then some physical therapy measures, rehabilitation, and we know that there is moderate evidence of massage and the acupuncture. Epidural injections may be helpful, especially particular steroids. Facet block or ablation, medial branch for RF lesion can help. And there is almost no role of surgery in acute low back pain because most of them resolve in 6 weeks. And how to prevent from becoming a chronic back pain? A significant portion of patients, 30 to 60%, may go to a chronic pain syndrome. And psychological evaluation and early mobilization of the patient are necessary. So as we look at the patient evaluation criteria, the radiology may be accused by unnecessary diagnosis and incidental pathologies. History taking is more important than examination, even, and more important than radiology. Ask the patient characteristics, and you must also know what the discogenic pain is, what the other disorders. In conclusion, mechanical low back pain and leg pain, diagnostic tests rarely necessary. Conservative therapies, exercise recommendations are good enough. Operate the patient, not the films, must be our logo. And seniors must make clinic and patient evaluation examinations with juniors. You can find our recommendation in the Spine Committee website, and there are open access papers on acute back pain. And please visit also Education Committee website to see our regular video recordings. Thank you for listening to me.
Thank you, Dr. Mehmet Zileli, for the wonderful update on the